Good evening, everyone. Thank you so much for joining us. So my name is Michael Reiter. I'm one of the radiologists here at Stony Brook. This is April Prank, one of our amazing nurse practitioners. So we co-direct the lung cancer screening program here at Stony Brook. And tonight we're going to give you a talk about just some basic introduction to lung cancer screening, some of the history, and then we'll have some time for questions at the end if anyone has any questions. So if that's, we can get started on the slides. All right, so these are some of the objectives, as you can read. We'll just go over some of the background about lung cancer. We'll get into some of the history of lung cancer screening, talk about the current criteria, and then April will jump in and do about our program here, some of the facts about that, and then a little bit about tobacco cessation. A lot of these numbers, some of you or all of you may be familiar with and have heard before. I find it still pretty sobering, even after the 50th, 100th time of hearing them, just how, severe a disease it is. And sometimes it doesn't get talked about quite as much as some other ones, even though it, plays a huge role in, for us in healthcare. So let's just go over some of them. So for lung cancer, right? So incidence-wise, it's the second most common cancer in the United States, right? So with breast being more common in women and prostate in men. But for mortality, it's the #1 killer in both the United States and the world. To even make the point, to make the point more impressive, right? So it kills more people than breast, colon, prostate cancer combined. The 5-year survival rates, when you look from stages, 1 to 4, obviously they're much better from stage 1 to 4. So at stage 1, it's roughly anywhere from 55 to 60%, depending on what study you read, and stage 4, 5% at best. So obviously the earlier you detect it, the better the chance of the patient having a better outcome. And then again, just for rough numbers. So if you look, this is the numbers from 2021 from American Cancer Society. So about 235,000 new cases and 131,000 or 132,000 deaths. So those numbers have actually been trending down since, if you look at the numbers since 2013, they've been trending down a few percent every year, which coincidentally is right around the time lung cancer screening started being implemented. That's probably not the only reason for it. There's different things like improvements in treatments, but there is a belief that plays a role in it as well. And so as far as lung cancer screening, we'll get into this more, the more details of it, but there were 2 trials, in the past decade that have shown a reduction in mortality using CAT scan to do lung cancer screening in high-risk population. So just a little bit more on the numbers. So again, these are fairly recent numbers. So as far as lung cancer goes, making up about 13% of all new cancer cases. But then if you look at the number of, how it's responsible for deaths, right, it's almost a quarter of all cancer deaths with a approximate 5-year survival of 20%. We'll get into that a little bit too. So these numbers are from 2017, but again, just to show the difference in, this is, new cases, incidence. So it being second in both men and women. Whereas for deaths, right, significantly higher number than for breast, colon, prostate. And so those were all for the United States numbers. It's pretty similar throughout the world, actually. And as I said before, for in the United States, the number of patients dying from lung cancer has gone down a few percent every year since 2013. It's actually still trending upward throughout the world. Right. So obviously, I think smoking cessation, I think we've done a better job here. And some other countries, it hasn't taken effect yet. And so you can see the lung cancer is the blue at the bottom. Right, you can see, so for lung cancer deaths throughout the world, it's the #1 killer of patients as far as cancer goes, and that number is still on the rise. This is specifically for women. So if you look at the red line, that's lung cancer. This is going back from the 70s up until the early 2010s. Right, and you can see from the 70s through the 90s, there's an increase in the amount of lung cancer. So I think, tobacco companies started to realize there was a whole half of the population that they hadn't really sunk their teeth into yet, right? So that was when they started to make a push towards promoting cigarette smoking for women. And coincidentally, or not coincidentally, you start to see the incidence of lung cancer increase in women in those times, and thankfully it's leveled out. And here's just an example of an advertisement from way back when it was, they were promoted as cool to smoke, especially for women. So if you look on the left-hand side here, so this is how the frequency of each stage at the time of diagnosis, right? So localized, being confined to the primary site, right? So less than a fifth of the patients at the time that we diagnose them will have it confined to just the lung. Regional will be a little bit higher, and obviously you can see 57% for distant. And like we talked about earlier, right, the survival is inversely related to that, right? The earlier you catch it, obviously the better the chances of them having complete cure and live a nice, long, healthy life. So, so again, some of these numbers depend on, where you get what source you look at, but they're always anywhere from, 55 to 60% for 5-year survival for localized, around 27 to a third, 33% for regional, and usually 4 to 5% for will be 5-year survival for if it's distant. And again, just to hammer this home, so the overall, if you take all stages, all comers, it'll be approximately 20% survival at 5 years, which, so this is a little busy, this slide, but so if you look at the pink dots for all the cancers, that's over a, I think, 7-year period from the 1970s, and then the little blue dots on at the end of the arrows are a 5-year period, 2007, 2013, right? So obviously, so the longer, and this is the 5-year survival, the numbers in percent. So the longer the arrow, right, the better the job we've done going from the 70s till, the late 2000s, early teens, increase in 5-year survival. So, if you look at things like prostate, breast, kidney, lymphoma, right, it's been a significant jump in 5-year survival rates over time due to a number of things. Some of it's due to, like for breast and prostate, there's screening available. There's obviously increased better treatments, better chemotherapies, better surgical treatments. But if you look all the way down at the left, the two worst, unfortunately, lung, pancreas as well, it hasn't really come very far, but specifically for lung, right? So, back in the 70s, a 12% 5-year survival rate, which, now is right around 20%. Currently. So we haven't really moved the needle very much in a very long period of time. And again, that's primarily due to the fact that by the time we diagnose them, they already have advanced stage disease where they are no longer curable. So, so just a quick backstory before I get into this one. So we won't go through the whole history, but just as a, right, so obviously, so knowing this, right, so it's been known for a very long time that, we diagnose, by the time we diagnose them, they're already in advanced stage. So obviously a screening would help. So people have looked into screening for lung cancer for, for decades now. So in the beginning, it was with chest x-ray. None of the trials that there were some pretty big trials. None of them have ever been able to show a mortality benefit with screening with chest radiographs. Once CAT scan came along, there was some excitement again to kind of get back into that, see if it would make a difference, because we knew we could find smaller and smaller nodules. The question was, would it actually provide a mortality benefit? And so there were a few studies early on that weren't big enough to, they weren't statistically powered enough to show that there was a mortality benefit, but they were very encouraging, which prompted this trial. So the National Lung Screening Trial, which the results were published in 2011 in New England Journal of Medicine. And so this really kind of changed the course. So this one was it had over 53,000 patients, and they were randomized to chest radiograph versus CAT scan for screening. And they got 3 rounds, a baseline, and then 2 follow-ups. And then they were followed clinically for years after that. And the final result, which is better shown on the graph here, is that right, so if you look at the left-hand graph, that's the number of cancers, which you can see. So the black line is the people in the CAT scan arm. The red line is the chest radiograph arm, right? So on the left, so on the left-hand side, you can see that there's a lot more cancers being detected on the CT side. And then most importantly, the thing that matters the most is on the right-hand side, which is mortality, right? And you can start to see after a while that they start to separate, and there's a decrease in mortality in the patients undergoing screening with CAT scan. And so the number for this trial was a 20% reduction in mortality, specifically from lung cancer. And then there was also a 7% all-cause mortality decrease, which we won't get into, but was also a positive response from the trial. So once this came out, obviously there was, a lot of excitement that we might actually be able to, put a dent in those numbers we had shown earlier about 5-year survivals for lung cancer. So a few things about the trial. So the criteria for you to be eligible for the NLST were you had to have had at least a 30-pack year smoking history, had to still be a current smoker or have quit within the last 15 years, and they were ages 55 to 74. So that's the only thing that they included. So if you had previous lung cancer, you weren't included. They didn't include any other secondary risk factors. Also, the way they what they counted as a positive, screen to get further worked up, they used nodules that were 4 millimeter or larger would count as positive, and then they would have to come back for additional, whether it was more imaging or potential intervention like a bronchoscopy, percutaneous biopsy, something like that. So that's what they used. So just as to give you an update on what we currently do, and then I'll backtrack to the NLST of why we've made some of these changes. So this is a very busy slide, so obviously this is not something that you need to look at or memorize or any of that stuff. But the main point I want to show it is right. So I think everyone is familiar. Mammography has been around for such a long time now. I think most people are familiar with BI-RADS. Right, there's no question as to what it is. So I think the goal has been to take that and apply it here. And there's a few other parts. Some of you get thyroid ultrasounds, there's TI-RADS now, and there's PI-RADS for prostate MRI, to just as an attempt to standardize the reporting so that there's less ambiguity of the reads between different radiologists, and that there's a more systematic approach to what to do with a finding. Because that's, I think, some of the issues that come up with some of these is that, one place you have one nodule, maybe they'll do something with it, and then someone else may recommend something different. So the whole goal of this is to try and standardize that and eliminate any of the ambiguity. So the main driving force behind this is the size of the nodule. It's not the best tool to differentiate a benign from a malignant nodule, but it's the most reproducible. So that's primarily what we use. And it's set up, they tried to set it up very, very similar to the BI-RADS, where if it's a 1 or a 2, that's essentially do nothing and we'll see you back in a year. A 3 is, we need to bring you back a little bit sooner than a year. It's not, it's, a little bit concerning, but not enough to do anything more than that. And then anything that's a 4, they subdivide it into 4, A, B, and C, but essentially anything with a 4 in front of it is now it's concerning enough that, we should do something else, whether it's a very short interval follow-up or potentially PET scan, biopsy, something like that. So, the whole, like I said, the whole goal is to try and make it as reproducible and uniform as possible and as easy to understand. So this is currently what we use. So this is not what they used when they did the NLST. One of the reasons for this was, well, I'll get into it here. So you can see, so in 2011, like I showed you, that was when the study was published in New England Journal of Medicine. It wasn't until 2013, so the United States Preventative Services Task Force, they finally, at the very end of 2013 in December, they gave based on the results of the NLST trial, they gave a recommendation of B for lung cancer screening, which was important because anything with a B or an A usually gets covered by insurance. And unfortunately, that makes a big difference, right? If something will get reimbursed, then it becomes easier to implement it in practice. So, but even after their decision in 2013, it wasn't until January of 2015 that most insurances had set up that they would start reimbursing for it. Now, despite that, even in 2013, I think a lot of places started actually doing screening once the USPSTE started, once they gave their recommendation of a B. I think most people took that as enough to, let's just start screening because it's the right thing to do, regardless if we get reimbursed or not. So the reason for some of the holdup was people were questioning for the NLST. So they had a very, an extremely high adherence to the protocol. and people thought that if once you started rolling this out to the general population, that the results may, you may not get the same reduction in mortality because you won't get as good adherence as they had in that study. There was also some concern about, false positives, the workup of those. Most of I think it was over 16 or 20 hospitals. The study was done throughout the United States and a few overseas. So they were all major tertiary care centers. They had an extremely low complication rate from any of their procedures, whether it was surgical biopsy or bronchoscopy or percutaneous biopsies. And again, some people are questioning, once you start doing it worldwide, nationwide, that those numbers may not hold up either. So there might be so the risk of false positives, will become greater, and patients may start to suffer some complications, and then incidental findings. So there were a few things that people had reservations about, and that's kind of why this took a while. So by creating this lung RADS and using a little bit different criteria than what they used for NLST, it'll reduce the amount of false positives studies that happen at screening. There's just a list of all the current organizations currently in support of lung cancer screening. And then as a follow-up to the NLST trial, this is the Nelson trial, which was done it's a Dutch trial. So they, and this was published in February of 2020 in New England Journal of Medicine. So not quite as big as the NLST. They had about a little over 15,000 patients. So there's a few small differences from NLST, but some of the differences are actually helpful because they give a little bit different information. So they used a little bit different inclusion criteria. So one there you can see is ages 50 to 74. So they included patients who were a little bit younger than NLST. They also had a different, it's not on here, I don't think, but there was a difference in, so you didn't have to have a 30-pack year smoking history. They did it by cigarettes. So I think it works out to somewhere between 15 to 20-pack year smoking history. So a little bit less smoking history was considered significant enough to get screened. And like I said, a little bit younger patients. And then they also, same as NLST, were randomly assigned, these were randomly assigned to either CT or nothing instead of a chest or x-ray. And they were followed at 1 year, 3 year, and then, so essentially it was 1 year gap, a 2 year gap, and then a 2.5 year gap in between their imaging, as opposed to NLST, which was always one. So some of the things that resulted from this were, so their overall referral rate, if you see on the third line there, was only 2.1% for a suspicious nodule, which means that, so their specificity was a lot lower than NLST. They used a little bit different criteria for what to count as a suspicious nodule, and they significantly reduced the false positive rate. So that was one plus that also kind of hammered home that you can do screening and have a very low false positive rate. And then the bottom numbers are just showing what the final results were, which are better demonstrated on the graph here. So again, the top one, similar to the NLST one, shows the incidence of lung cancer, so the actual number of cases of lung cancer. And again, the blue line is the group undergoing CAT scan. The red group is no imaging, right? And you can see there's a significant more higher number of cancers detected in the CAT scan group. And then the bottom one is again, the more important one, the mortality, which shows a significant decrease in the amount of deaths from lung cancer in the group undergoing CAT scan. So the number was overall was 25% for, or 24% for all patients. And it was actually even higher for women, but there was only, as you can see, a little less than 3,000 women included in the group. I think in the Dutch, there's just not a very high population of women who smoke. So based on these two trials, this is currently where we're at as far as what criteria patients would need to fall into in order to be eligible for screening. So there's a few different ones out there, which makes it confusing. So we'll go through them all. So the NCCN, so this has kind of been their criteria since the beginning, since back in 2013 or 14. So the group one is essentially the NLST patients. They go a little bit above. Instead of 55 to 74, it's 55 to 77. But the same pack year history and the same thing, you have to be a current smoker or have quit within the last 15 years. At the time, they had created a second group, which they thought these people have the same lifetime or a relative lifetime risk of developing lung cancer. And so they wanted to include these patients for lung cancer screening because they thought they would have similar benefit as those included in group one. And that was anyone 50 years or older with a little bit less smoking history, PACU history of 20 years or greater, and then any additional risk factor, and these are examples of some of them. So family history of lung cancer, if you personally have had lung cancer, asbestos exposure, things like that. There were some people who, again, this wasn't approved a few years ago by a lot of, it wasn't endorsed, I should say, by a lot of other groups at the time, because they felt that the NLST criteria, the group 1 criteria that was what was tested, and that's what showed the mortality reduction. And so, again, there was questions over whether you would get the same reduction in group 2. But since the Nelson trial, right, they had people 50, going down to ages 50 up to 77, and they included people with 15 or 20 PACU histories, and they showed, again, a significant 24% mortality reduction. So obviously it does work. So that's the NCCN's criteria. The USPSTF updated their criteria recently. So now it's from ages 50 to 80. Again, they lowered their PACU history to 20 years, and then the rest is the same, current or former smoker within 15 years. Unfortunately, Medicare has yet to follow. They usually follow suit with USPSTF, so that probably will be happening at some point shortly, where it will match the top. But that's currently where they sit there. And then this is I'm going to show at least one image as a radiologist of a CAT scan. But again, so the reason that this is so much improved compared to doing chest radiograph screening is that, right, so you have to imagine everything from the top of the image to the bottom of the image, on the chest radiograph will get flattened, as overlap, right? It becomes a two-dimensional image. So being able to see smaller and smaller nodules just becomes hard between, with all the different vessels there. You can see the ribs in front, below, right? You have a heart there. So nodules like this would be much harder to see on chest radiograph than on CAT scan. And this was, I didn't actually mention this, but this was another one of the reasons I think it took a while. There was some concern about radiation risk from CAT scan, right? People getting annual CAT scans. If you're starting at 55 and you may go, 20 years till you're 75, right? A CAT scan every year, that makes some people nervous. So just to go over a little bit about radiation risk. So listed a few things here. So we report this in millisieverts. So if the top one is probably the most important, I guess, baseline number to know there. So like every person on Earth is, well, not every person on Earth, I should say, every person at sea level is exposed to approximately 3 millisieverts a year of radiation. The higher altitude you live in, the more you're exposed to. So if you live, like, for example, in Denver, it'd be 5, right? If you fly a lot, again, you're at higher altitudes, you're going to get a little bit higher exposure. In terms of medical imaging, and again, this is a little hard because the dose will change. No two patients will get exactly the same exact dose every time they go in, but these are kind of averages for an average size patient. So a little bit bigger patient will probably get a little bit higher dose, and a smaller patient will get a little bit smaller dose. But on average, a standard chest CT is somewhere around the range of 6 millisieverts, which is a little bit lower than the number, because I remember in medical school, they used to always say, well, it's about one chest CT is about 100 chest x-rays. But with the CAT scans that we do for screening, it's a very low dose technique. So the number you can see there is 1.5. And I would say, honestly, more than half of the patients get a lower dose than that we do. So it's somewhere in the range of about 10 chest x-rays. And as the technology continues to get better, that number will only go lower. So it'll get to the point where it'll be the equivalent of maybe 5 x-rays, 6 x-rays. Over time. So radiation risk, it should not be something to discourage patients from getting screened. If you have patients who are worried about radiation risk, you should assuage their fears. It's right. You think if you have patients in the hospital who get 5 x-rays, right, no one will bat an eye at that. It's going to be roughly the equivalent of that in the near future. So don't not do it because of radiation risk. And then I'm going to turn it over to April now. She's going to just go over some of the details of our lung cancer screening program, as well as some stuff about tobacco cessation.
Hi, good evening. Thanks for joining us. So Dr. Reiter talked about the background a little bit, about how we came to today with lung cancer screening And so what we did at Stony Brook, we had been talking about lung cancer screening and implementing a program for a long time. And we were really excited to start our program actually in September of 2013. So right before the US Preventive Service Task Force gave their recommendations, but certainly after the NLST trial, we knew that it was moving in that direction. We started our program right away with insurance reimbursement. We crossed our fingers, hoped for the best, and we have been successful with obtaining insurance authorizations for our patients who meet criteria. So this is just a flow chart of pretty much what you can expect your patient to receive when you refer patients. And for all of you who are joining us who send us referrals, we appreciate it. Refer to us or to another program. We really want to see as many people who meet criteria get screened. So patients will undergo, you see top left there, a shared decision-making visit. That is a requirement for Medicare. If the patient is not a Medicare patient, the other insurances don't require it, but we do a shared decision-making visit formally for all of our Medicare patients. And informally, by phone, it doesn't have to be a billable appointment for the other insurances. And what's involved in the shared decision-making visit is really just establishing that the patient meets criteria and then giving the patient a little heads up on what to expect, including radiation risk, like Dr. Reiter explained, the potential benefits, the risks and benefits of lung cancer screening. We also like to really give our patients a heads up that about 50% of the general population will have a pulmonary nodule, for example. I always like when they know it ahead of time. This way, when I'm giving them results and they have 2 nodules or 4, they're not as worried. People who meet criteria, they get scheduled for a low-dose CAT scan. That gets done. And oftentimes, same day, they come in for their office visit. It might be a few days later. At that office visit, they see me. I'm currently the only nurse practitioner in the clinic for now. As we grow, that'll increase. But at that visit, they're getting their results. They're getting an abbreviated physical exam. And about half of our patients are current smokers. So they are receiving extensive tobacco cessation counseling. We'll talk about that briefly. So patients, the majority of our patients are a low lung rad 1 or 2. And so the majority of our patients, the recommendation is for them to come back in a year. So the patients who are 1 or 2, they get their results. You as a healthcare provider can expect a full note from myself and a copy of the CAT scan report with the recommendations. Patients who are lung rad 3, so they're most likely coming back in 3 months or 6 months. They'll again, you'll expect the same thing. Patients will be a little more nervous. So if somebody's especially nervous, I'll usually give your office a call. And then the lung rad 4, so people that we're really concerned about, they either need a CAT scan in 3 months or they need some sort of intervention. Those patients will always get presented at our interdisciplinary thoracic tumor board, where we get a group consensus. Even though we have guidelines through the American College of Radiology, we get a group consensus. And if a patient has what looks like a cancer, you can expect to get a heads up. This way, when you get a call in your office the next day, you'll be aware that this patient had lung cancer screening and we're concerned about them. And then treatment as indicated. Here at Stony Brook, our lung cancer screening program is housed in the Department of Radiology, and we're very connected to our lung cancer evaluation center, where we have the thoracic tumor board and where our radiation oncologists are, and oncologists, thoracic surgeons, pulmonologists, interventional pulmonary, and where our social workers are. So that's pretty much the flow of our program. So what are our results? We have screened to date. At the time of this slide, which is not that long ago, we had 1,500 patients screened and 56 diagnosed with cancer. Today we have another one, so it's 57, but it's about 3.7%. It usually runs around 3%, 3.3%, which is really similar to national numbers. You'll see most programs report about a 3% prevalence of lung cancer. So our stage distribution prior to lung cancer screening, this is all lung cancers that came into Stony Brook. We picked a block of time. Our lung cancer evaluation center opened its doors in 2002 under the leadership of Dr. Billfinger, and is still, running today. And so these numbers, you can see that, the majority of patients that were diagnosed in a 5-year window were stage 3 and 4. So the blue bar is Stony Brook numbers, the red bar is New York State numbers, and the gray bar are national numbers. And you can see that our numbers are similar to state and national. And unfortunately, a good percentage of patients are diagnosed later stage. We always remind patients that the lungs are not very innervated. So oftentimes you're going to get symptoms later on when it's either advanced or involving the pleura, et cetera, which is rather innervated. This is the stage distribution to date with our 56 patients. You can see that the majority of our patients are stage 1 and 2. Actually, 77% were stage 1, 11% stage 2, and the rest were 3 and 4. This is the histology distribution. You can see that this histology also is quite similar to lung cancer histology overall, with the majority being adenocarcinoma. Second most common is squamous. And then we have all sorts of mixed adenosquamous, and we have some of our neuroendocrine tumors. And we actually have in our program, we diagnosed 2 small cells, and I'm extremely happy to tell you that they were both early stage small cells. And, for those of us in the field and working with lung cancer, you know that it's a rare thing to find a very limited small cell. So these are CDC numbers. This Dr. Reiter showed you this before, just to remind you that the overall 5-year survival rate for lung cancer is about 20% these days. The next graph, forgive the graphics, but you can see that with the first, we have 30 patients that have been diagnosed 5 years or more, and we have an 85% overall survival rate in our lung cancer screening cohort. Very low number, but we're looking for this to maintain this great survival rate. As far as smoking status of our patients screened, it's about half and half. Current smokers are 46%. And what we've found is that the lung cancer screening appointment is a great, it's a great opportunity to discuss. We have a captive audience. Patients are concerned. Any of us who have undergone any kind of cancer screening recognize that there's some anxiety. So we really try to capitalize on this, not to manipulate the anxiety, but to just really make the most of that teachable moment. The ILCAP housed, all over the world, but Claudia Henschke and David Yankovic at Mount Sinai have screened well over 70,000 patients, and a lot of their data is just wonderful to look at. But they showed that 23% of patients had quit automatically just after their baseline CAT scan. So we can't take full credit for the people who quit, but we do know that there are, 77% who don't quit. So we really try to, begin their tobacco cessation journey at that first visit. And those numbers are very high. It's more than 4-fold over the general population who's trying to quit, which have about a 4% success rate. The next few slides are just to give you some information of what we share with patients. We all know risks from smoking, so patients are reminded of the risks from smoking. Many of them are very nervous, so we also talk about the benefits of quitting. And unfortunately, that slide didn't make it into our program tonight, but we really like to talk about the benefits of quitting and how your heart is very forgiving, for example, and your risk of sudden death by stroke or heart attack is at 50% of what it was a year after you quit smoking. And we work from there, telling them that it's never too late. We use the 7 FDA-approved medications, which include bupropion and varenicline. And this is what our patients would be told, that the bupropion doesn't work for everyone, but it works for many people, not only to help you with cravings, but it also help you, not to be as sad, because for many people, giving up smoking is like giving up a best friend. And the varenicline, years ago when we first were using varenicline, as most of you know, it was day 8, you quit smoking. Now we're happy to share with them the, step process where they half their frequency at day 8, and then they half again at week 4, and half again at week 8, half again at week 12. We get a lot of takers for that. And then the 5 nicotine replacement medications, as you most likely know: patch, gum, lozenges, nasal spray, and inhaler. The gum and lozenges are not reimbursed by insurance. The others should be. Sometimes we have to do a peer-to-peer. And the one that I have found that people are really doing well with is the inhaler. It's something you hold in your hand, it's something you put to your mouth, and it's nicotine to the brain, so it's helping out a lot. At the Stony Brook program, as I said, a little less than half are smokers. Everyone except for one patient, if they're not ready to quit, if I ask, and we do motivational interviewing, this is a whole nother topic, and we're actually going to be happy to share this with you in June on just tobacco cessation. But when patients are in the driver's seat and they're asked, would you like to talk about this? Is it okay if we talk about this? Even the ones that aren't ready to quit, almost every single one of them is agreeable to cut back even by 1 cigarette a day. And we talk about, mutations from combustible cigarettes, and how even cutting back from 1 cigarette a day is helpful. When they start that, and they're agreeable to follow-up telephone call, etc., it's really wonderful to watch them cut back and to go from 2 packs to 1 pack to a half a pack to, eventually being a quitter. We also like to remind them, not only is it costing them money to smoke, but it's healthcare costs. The American Cancer Society actually estimates $35 in healthcare costs for every pack that's smoked. It's very substantial. It's billions of dollars. So we have a 32% quit rate of our patients. We recently published at the ATS, looking back a retrospective review of 244 of our patients who were current smokers at the time of the visit. There was a 32% quit rate within 2 years of screening. It was a self-reported, so it's not a flawless look back, but self-reported was 32% quit rate, and the quit rate was defined as without smoking for 6 months. We give our patients a whole bunch of resources. It's good for us as providers to be reminded of just how much money goes into tobacco cessation at the state level, at the county level, and everything is online. And I give our patients a packet, even though all of this is available on their computer. I like to print out a packet and give it to them and come up with a quick quit plan so that they leave with a quit plan actually on paper. We're involved with a lot of ongoing research and efforts here at Stony Brook, including tissue banking. There's imaging predictive models in multiple departments and divisions. We're trying to increase our awareness of lung cancer screening, and currently brainstorming to come up with some other innovative ideas to decrease disparities with lung cancer screening. We love to celebrate the progress, and if you look at this advertisement, more doctors smoke Camels than any other cigarette, we've certainly come a long way with people getting screened, and so we hope that you'll reach out to us if you have any questions. We couldn't do the screening program without a whole bunch of people. Dr. Billfinger, like I said, he founded the Lung Cancer Evaluation Center in 2002. Lisa Reagan is our program coordinator. Dr. Reiter, who you met, is our thoracic radiologist who oversees the program as well. And there's many, many people, including our surgeons, our pulmonologists, our radiation oncologists, our oncologists, our social workers, our psychologists, all of our administrative people, all of our radiologists, our thoracic radiologists. I don't want to miss anybody. Just so many people go into this program, and we really appreciate them, and we want to give them credit. So you can send your patients our way by referring them to our number. If you are a Stony Brook affiliated provider, you can send a a request through the lung cancer screening pool. It's called Lung Cancer Screening Pool or LCS pool. You can also always send an email or you can call the number. And if you would like a personal visit from Dr. Reiter and I, we're happy to visit, go over more numbers in detail, and we welcome your feedback. I also want to thank Genetech and Lilly for providing funds for us to provide this program for you at no cost. We really appreciate their support. And at this time, I think Linda Billy, who is hosting our evening, is going to let us know if there's any questions in the chat. And if you're watching this not live, we're available to answer those questions via email.
Thank you, Dr. Reiter and Dr. Plank. That was very informative, and you presented it so well that nobody has any questions. So we thank you for your time. If they do have any questions, they can call your number at 631-638-7000, or they can email COE, the COE office at stonybrookmedicine.edu. Thank you so much and have a good evening.